dibandingkan dengan luar negeri atau negara barat. Itu yang pertama. Jadi beliau concern untuk memunculkan nilai BMI-nya berapa. Kemudian yang kedua adalah terkait dengan chart tumbuh kembang. Jadi beliau concern apakah mahasiswa itu mengkaji tentang chart tumbuh kembang, karena itu bisa digunakan untuk menilai stunting. Dua kategori tersebut bisa digunakan untuk melihat stunting. Begitu. Kemudian tadi masalahnya adalah bahwa si anak itu makannya bagus ya, tetapi diagnosanya adalah defisit nutrisi. Dan diketahui juga bahwa kurangnya pengetahuan orang tua. Nah, di sini yang ditanyakan Profesor Catherine Wang tadi adalah informasi seperti apa yang tidak dimengerti oleh orang tua. Apakah itu terkait dengan nutrisi dan sebagainya. Itu yang dikonsenkan oleh Profesor Wang. Kemudian yang presentasi yang kedua terkait dengan tuberkulosis tadi, mungkin agak sudah jelas ya, Mas. Yang kedua tadi, presenter yang kedua, bahwa beliau concern bahwa dengan 5 diagnosa dengan 3 hari intervensi, kemungkinan impossible untuk bisa selesai gitu ya diagnosanya. Mungkin tadi yang dimaksud adalah diagnosa selesai ketika masa praktikumnya selesai, gitu ya. Jadi overall bagus sih untuk komen di yang kedua, gitu. Kemudian ada beberapa part untuk intervensi atau implementasi yang tidak straight through atau direct ke masalah keperawatannya, seperti itu. Itu mungkin.
Okay, thank you, Eric. Did you translate that I say they are doing very well?
Yeah, sure.
Otherwise, the student will get hurt because I say too much.
No.
I think you all did great job with your patient. Yeah. Okay.
Ya, Profesor Wang memuji presentasi teman-teman dari Akper KESDAM bahwa presentasinya sangat komprehensif dan sangat bagus. Hanya sedikit input untuk memperkuat diagnosa yang dikembangkan, bahwa perlu adanya pengkajian terkait dengan BMI sama chart tumbuh kembang ya, supaya bisa lebih komprehensif. Yes, Professor, I said that you are really appreciate with those two presenters.
Okay, thank you very much for Eric's help. Hi, good morning. Terima kasih. Okay.
Pak Arik, mungkin sampaikan dengan Prof. Bisa share tentang teori tumbuh kembang ke kami, ke KESDAM, sehingga kami bisa mempelajarinya lagi. Ada teori yang baru.
Okay, Professor Catherine Wang, the Deputy Director, asking about the possibility maybe next time that they will inviting you to explain about the latest theory about growth and development, because they are really interesting. Your expertise in the pediatric nursing, right?
Yes, I am.
Yeah, maybe next time they will invite you to explain or give a speech or a presentation about the latest or the new theory about growth and development, especially in nursing.
Terima kasih. I'm flattered to be invited by Deputy Pada, Deputy Director Pada, and we will try to see. I have to talk to Eric because he's the one who coordinates everything. We will see how we actually can able to be online and share some of information from my specialty in pediatrics and family care, and also the research that I have done. So maybe next time, I'm honored to be invited, and thank you very much for that. Yeah, we will see with the Eric. We'll talk a little bit more about Ericsson. We will see how we can manage the time and match the time, because we are going to have our semester start soon, so can be very busy. Okay, so it's because this time next week is our semester start, and so this week is actually quite a free time at the moment, you know, like having meeting at the same time, so it's all very squeezy schedule. But I will talk to Eric a little bit more and how we can manage that. But thank you very much, Deputy Director Padam. We will, I'm sure in the future, we will have more opportunity online to share some of the information, both schools and university. Thank you.
Ya, jadi Bu Baidah, kalau dijelaskan teorinya mungkin ini ya, lama, butuh waktu panjang kalau hari ini dijelaskan. Jadi tadi saya menyampaikan bahwa mungkin di lain waktu bisa mengundang Profesor Catherine Wang, karena beliau spesifikasinya di pediatric nursing sebenarnya. Jadi bisa diundang atau memberikan salah satu presentasi yang lebih spesifik terkait mungkin tadi tentang teori tumbuh kembang yang terbaru. Jadi nanti kita bisa diskusikan, mungkin agak lama nanti. Jadi proposalnya masuk dulu, jadi kita diskusikan karena semesternya udah mulai. Tapi insya Allah nanti bisa dikondisikan. Nanti kita butuh diskusi lagi ke depannya.
By the way, 5 years ago, I went to Surabaya.
Oh.
And Jakarta before 5 years ago, because I went to a conference by myself to Indonesia and Surabaya. So we will have opportunity to meet each other. Thank you in the future.
Thank you, Mom Catherine.
Dan ini Mas, ada yang tanya di chat, jenengan mau
maaf Farid, mungkin mahasiswanya mau yang komentari yang tadi.
Iya, sure.
Berkaitan dengan masukan dari Profesor tadi.
Alright, okay, sure.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Prof, untuk pertanyaannya. Mohon izin kami menjawab dengan bahasa Indonesia. Izin, Prof, mengenai
Professor Wang, the student is trying to a little bit how to say, respond to your comment and questions by showing this document. Maybe later I will help you to translate, because he is trying to explain it in bahasa Indonesia. Monggo Mas, silakan.
Okay, this session only have 5 minutes left. Okay.
Right.
Siap. Pemantauan pertumbuhan dan perkembangan anak yang menguatkan kami mengatakan anak tersebut mengalami stunting. Yang pertama yaitu pemantauan pertumbuhannya dengan memantau status gizi anak. Kemudian pemantauan perkembangannya kami menggunakan kuesioner pra-screening perkembangan atau KPSP. Untuk datanya tidak kami masukkan PPT karena terlalu panjang, jadi kami buat dalam bentuk lampiran. KPSP dan hitungan. Siap. Untuk pemantauan pertumbuhan, sini udah ada antropometri anak berupa tinggi badan, berat badan, lingkar kepala, lingkar lengan atas, kemudian jenis kelamin laki-laki. Karena pemantauan pertumbuhan jenis kelamin laki-laki dengan perempuan berbeda. Untuk penentuan ambang batas set score yang menyatakan anak itu mengalami gizi buruk atau stunting atau gizi berlebih, dari hasil pengkajian kami umur anak M atau pasien pertama yaitu berat badannya 6,8. Ini pemantauan berat badan berdasarkan umur. Ambang batas set skor anak berada kurang dari -3 SD, sehingga anak berada dalam kategori berat badan sangat kurang. Kemudian panjang badan atau tinggi badan menurut umur dari tabel menurut Kemenkes RI 2020, umur anak M 26 bulan, tinggi badan 79 cm, di tabel berat indeks set score, panjang badan atau tinggi badan menurut umur. Sehingga pasien pertama atau anak M ini berada dalam ambang batas set score -3 SD. Sehingga anak berada dalam kategori pendek atau stunting. Kemudian yang ketiga, pemantauan gizi menurut berat badan menurut panjang badan atau tinggi badan. Tinggi badan anak M 79 cm dan berat badan 6,8 kg. Ambang batas set score yaitu -3 SD, sehingga anak M berada dalam kategori gizi buruk. Kemudian yang keempat yaitu pemantauan gizi menurut berat badan, menurut panjang badan atau tinggi badan, di mana IMT anak M 10,89 kg per meter pangkat 2. Anak M berada pada batas set score yaitu kurang dari -3, yaitu dalam kategori gizi buruk. Kemudian pasien 2 tidak kami jelaskan karena terlalu panjang. Lanjut ke pemantauan perkembangan menggunakan kuesioner pra-screening perkembangan atau KPSP berdasarkan usia. Klien pertama anak M usia 2,2 tahun atau 26 bulan, sehingga kami menggunakan KPSP anak umur 24 sampai 39 bulan. Dari hasil pemeriksaan KPSP kami untuk pasien pertama, hasil jawabannya itu cuma 6, yang 4 tidak. Kemudian pasien 2 umur 40 bulan, hasil dari pemantauan KPSP jawabannya 5. Sehingga anak mengalami perkembangan yang tidak sesuai dengan usianya. Jawabannya ya atau kurang, perkembangan interpretasi yaitu penyimpangan, sehingga anak kami sarankan kepada orang tuanya untuk merujuk ke rumah sakit atau puskesmas terdekat. Izin demikian Prof, penjelasan kami, sehingga anak tersebut masuk dalam kategori stunting atau mengalami gangguan pertumbuhan dan perkembangan. Terima kasih. Kemudian yang siap?
Ya, masih ada Mas?
Izin untuk yang defisit nutrisi, di sini kami menggunakan buku diagnosa SDKI tahun 2017 dari data subjektif dan data objektif pada saat kami melakukan pengkajian. Di antaranya data subjektif kami dapatkan yaitu pasien atau keluarga itu mengatakan anaknya itu cepat kenyang, kemudian nafsu makan tidak ada atau susah makan. Terus dari data objektif kami mendapatkan anak itu tampak kurus, dibuktikan dari status gizi dan KPSP-nya tadi. Sehingga kami bisa mengangkat diagnosa defisit nutrisi sesuai dengan standar diagnosis keperawatan Indonesia. Kemudian yang diagnosa kurang pengetahuan, pada saat kami melakukan pengkajian, orang tua pasien atau klien itu sering bertanya, dan pada saat kami tanya mengenai pertumbuhan dan perkembangan anaknya itu tidak mengerti sama sekali. Itu dari data subjektif yang kami dapat dari pasien. Kemudian data objektif yang kami lihat, yang pertama anak tampak kurus, kemudian yang kedua lingkungan di sekitar rumah pasien itu sangat tidak memenuhi syarat. Kemudian dari MCK, WC itu langsung ke sungai. Terus air bersih yang dikonsumsi baik untuk minum, masak itu langsung dari sungai. Sedangkan buang air besar di sungai. Kemudian untuk mengenai kurang pengetahuan, pendidikan dari orang tua klien atau pasien itu dua-duanya lulusan SD. Sehingga kami bisa mengangkat diagnosa kurang pengetahuan. Karena kita tahu penyebab dari stunting itu ada penyebab langsung dan tidak langsung. Di mana penyebab langsung dari stunting ini diantaranya dari orang tuanya. Baik itu MPASI, ASI atau MPASI-nya. Kemudian penyebab tidak langsung itu rata-rata dari lingkungan. Berapa literatur yang kami baca, stunting itu penyebabnya itu dari faktor lingkungan. Baik itu air, kemudian sanitasi, dan lain-lain sebagainya. Thank you, Prof. Demikian jawaban dari kami. Kami kembalikan kepada moderator.
Maybe let me just summarize what the students explained about your response. Actually, Professor Catherine Wang, the student is really done well for the report. What you have asked about the BMI and the how to say that the growth and development screening, they did in the complete report. Then I will send it to you later, because I think the school already sent it to me in the English version, so I will send it to you. So actually the students did very well for the screening. They do grow and the development screening, pre-screening questionnaire, use that, and also did the using anthropometric assessment. So I think it's complete. But they just didn't put it in the presentation because it's will be too long and wasting the time. All right. Thank you.
Thank you.
Monggo Mas, saya kembalikan ke MC.
Oke, terima kasih. Oke, thank you for the proposal, for the comment for our presentation about the data, of course, and thank you for Mr. Eric for the good translation. The next we are going to the session 2 about the presentation will present by the student of National TV University. The first presentation will discuss about caring for a patient with the bile duct stunt controlled colonitis from the case study delivered by J.C. Cheng, nursing student, nursing department of National TV University. Time is yours.
Okay. Hello, everyone.
Hello.
Can you guys hear me? Can you hear me
We
well?
can hear. Yes.
Yes, we do.
Okay. Thank you. Thank you for the moderator, and thank you for your school for having me this opportunity to share the content with you all. I'm just wondering that, am I sharing the screen or?
Yes, you can.
Yes, we know.
Please give me 1 second.
Screen.
May somebody help me to share the screen, because I think at this moment I'm having problem sharing the screen. Or can Dr. Catherine help me to?
Let her to be co-host so she can share
You
screen.
you need to you needed to upload your PowerPoint presentation on the dialogue, so that someone can actually download it for you and do the sharing the screen. So did you actually see the square with the arrow in the middle sharing the screen?
Yeah.
Items you did. So can the host open up the give Jesse the authority to actually share this PowerPoint? Because sometimes if the host actually not sharing the authority, then you can't share the screen.
Bisa nggak no di share-nya dia?
Okay, Jesse, I will help you to share the screen because I have your PPT.
Okay,
So
thank you.
or wait a second.
Kalau Mr. Eric.
Is that visible?
Yes, thank you. Okay. Okay, so I'm really thankful to have this opportunity here. And let me simply introduce myself. I'm the student from National Taipei University of Nursing Health Science, and I'm Jessie Chang. So today I'm going to make a simple introduction about my report, which is the caring for a patient with bile duct stone concurrent cholangitis. So yesterday, Dr. Stacy has mentioned really detailed about our use in Taiwan, which is specifically for soap and soapy, and I'm actually using that one as well. So I'll just mainly get into the patient description and about the specific case. So first, for the patient description, it's about a guy, Dr. Xie. He's 64 years old and his career is a taxi driver. His height is 158 centimeter and 77.5 kilograms. He had been admitted to the hospital for my caring time is around 1 month, almost 1 month, 20 days. And he done total right lobectomy, open approach cholecystectomy, and he has the diagnosis of calculus of bile duct with cholangitis. Okay. And the case history and his reason for admission is that he indicated that he has suffered from high blood pressure, type 2 diabetes, and hyperlipidemia for approximately 30 years, and he is regularly taking oral medications. However, due to fever, abdominal pain, and discomfort, he went to Taipei Mackay Hospital for treatment. And the abdominal computed tomography examination was arranged to be cholecystitis. So it was recommended to be admitted to the hospital for antibiotic treatment. For his case presentation, Mr. Xie went to the emergency department on June 6, 2020 for the treatment since he had abdominal pain, fever, and diarrhea for 2 days. Abdominal computed tomography examination showed that the right intrahepatic bile duct was dilated, and which is suspected cholangitis. Other than that, the left kidney suspected adenoma or myelolipoma, as well as which is fatty liver. After being treated with antibiotics, he returned home. However, he returned back to the hospital arranged for detailed examination, which is liver MRI, and showed that mild cholecystitis. After 2 weeks later, June 30th, an open right hepatic lobectomy and cholecystectomy were arranged with a blood loss of 500 cc during the surgery. Okay, next page, thank you. And then he was transferred to the intensive care after the surgery. On July 2nd, he was transferred from the intensive care unit to the general ward, which I was. The body temperature on the day transfer was 38.3 to 38.4 degrees, which is okay. The chest x-ray showed bilateral lower lung collapse and pleural infusion, and post-operative fever may be related to lung insufficiency and infection after the operation, which is today I'm gonna focus on. After he has been using aerosol mask 50%, the SpO2 is about 90 to 92%. So it is changed to high flow nasal CPAP 10 liter per minute, which can maintain the SpO2 up to about 94 to 96%, which is arrangeable. On July 5th, the chest X-ray showed that bilateral pulmonary hydrops. So they consult with the thoracic medicine was performed. After the consultation, they just arranged for the oxygen level. Next page, thank you. Eric, please, next page, thank you. Okay, so I think there's a previous page.
Oh, wait.
Sorry.
This one?
Yeah, thank you. So on July 8th, the more important is that the case observed a small amount of light red fluid leaking from the suture removal site from the surgery. So then the nursing team decided to put a size 10 naltrexone tube. After all that, the case was evaluated by the doctor on July 20th and indicated that the current condition was stable and there was no discomfort. So the patient could be discharged home. Before any assessment and evaluation, I will like to share some literature review. Due to the rise of Western culture, Chinese people have the habit of eating Western diets. Foods usually contain high-fat ingredients, which also leads to the increasing incidence of gallstones and bile duct stones. Intra-hepatic bile duct, which is IHD stones, are the presence of stones within the intra-hepatic bile ducts, particularly proximal to the confluence of the left and right hepatic ducts. Such stones are characterized by their recalcitrance and frequent recurring multiple treatments if without proper treatment. Biliary strictures and stone retention can lead to recurrent cholangitis, liver abscesses, secondary biliary cirrhosis, portal hypertension, severe to heptis, or even the death from liver failure. So treatment of intrahepatic bile duct stones remains difficult and challenging because the incidence of post-operative residual stones remains high and recurrent stones may occur. The treatment of intrahepatic bile duct stones requires complete removal of intrahepatic stones and prevention of recurrent stones. The advantage of hepatic lipectomy is that it can remove the part of the liver that includes both intrahepatic duct stones and lesions at the duct. So high stone clearance rate and reduced stone recurrence rate can also prevent the occurrence of cholangiocarcinoma. For my physical examinations for this patient, Mr. Xie, I used the one that is usually used in medical surgical ward, which we usually make a full body physical examination. So this includes mainly 3 parts. The first one, which is body level, which includes general appearance, nutritional status, sleep, daily activities, physical health, and substance or alcohol abuse. And today I'm just gonna focus, since there's not so much time, I'm just gonna focus on his respiratory system, which is the physical health part. The second main level is emotional level, which includes emotions and mood. And the last one is intelligence level, which includes thinking, perception, and cognition. Oh, sorry, there's 5 parts. And the fourth part, that was the body examination. And the second part was actually social dimension, which includes interpersonal relationships, self-concept, role functions, family status, and cultural factors, and which the last is for spiritual level. So as I said, I'm just going to focus on today's main problem, which is the respiratory system problem. The case indicated that he had suffered from asthma for about 10 years without any special medication, which is his past history. The case was admitted to the hospital on June 29, 2020. The chest X-ray showed that the lung lines increased and the bilateral intercostal angles were obvious. On July 2nd, the patient had fever after the operation, so the chest X-ray results were followed up. And bilateral lower lung collapse and pleural infusion may be related to pulmonary insufficiency, which is today's main problem, and infection after the surgery. Continued antibiotic treatment, spirometry use, which is a tool, and inhalation therapy drugs to promote lung expansion. After using aerosol mask, 50% SpO2 is about 90 to 92%, and was changed to high-flow nasal CPAP. On July 3rd, the case was measured 1.5 bowls by spirometry, continued to use inhalation therapy drugs, and encouraged the patient to sit up, take deep breaths, and cough exercise to promote lung expansion. The case was followed up on July 5th by the chest X-ray examination results of bilateral pulmonary hydrops. So the consultation with the Department of Thoracic Medicine came from evaluation, and they arranged a chest X ultrasound scan and a thoracic ultrasound guide on July 7th. There was a small amount of fluid in the right lung. A total of 50 cc yellow clear fluid was collected. Joint care in the thoracic department, oxygen was changed to aerosol mask 40%, which can maintain the SpO2 to 95%. Until July 17th, the case was not carrying oxygen and could take deep breath, coughing, and get out of bed by his own. The appearance of his chest of the inspected case is symmetrical. The sternum has no lordosis or concave. The anterior posterior diameter, the left-right diameter is about 1 to 2. The breathing action is the same as the chest and abdomen. And the breathing frequency is about 20 to 25 breaths per minute in the intensive care unit after the operation, and about 20 to 25 after. During care, the breathing frequency is about 16 to 22 breaths per minute. The angle of the ribs is less than 90 degrees, and the breathing action is chest breathing. The breathing's ups and downs are the same. The abdominal and the chest are up and down. The case also does not breathe through the nose, occasionally uses open mouth breathing, and does not respiratory auxiliary muscles. There was no other specific problems. So the evaluation results for this specific area respiratory system is that the patient suffered from impaired gas exchange, which may be related to the effect of anesthesia on lung expansion after surgery. For SOAP and the nursing care plan, he has several nursing problems, which are acute pain, bloating, sleep pattern disturbances, lack of knowledge, impaired skin integrity, potentially dangerous, and infections. However, today I'm just gonna focus on the breathing problem. So this is my SOAP. For the S is, these are mentioned by Dr. Stacy yesterday, so we'll just jump over. These are the I and E. So his subjective data is that he sometimes gets, he said that I sometimes get short of breath while moving, and I sometimes find it hard to breathe. For the objective data, he has affected the expansion of the lungs, and the X-ray showed bilateral lower lung collapse and pleural infusion, and there were crackles and stridor sounds, and 50 cc of yellow clear effusion. For analysis, I decided to analysis as impaired gas exchange, which is because the post-anesthesia surgery affects atelectasis. For my plan, short term, I divided into short term and long term. For short term, the case can reduce oxygen to aerosol mask with SpO2 94% before July 8th. For long term, the patient can carry out daily living activities before discharge. Implementation for Plan 1 is to communicate with the patient and family members to establish the nursing problem. And second is to access respiration rate and pattern, oxygenation changes, and such. The third one, adjust the position according to the individual's most comfortable position. And the last one is to observe the chest X-ray, whether the water accumulation is reduced or improved. The fifth one is to inform the case, family members and his caregivers that any health education that is related. The sixth one is when assisting the case with daily living, still has to retain his physical strength and observe the breathing situation. And the seventh, which is medicine, that is medicine or either medicine or respiratory inhalation, which is prescribed by the professions. And the last one is to give high flow nasal CPAP as prescribed by the doctor as well. And my evaluation is on July.
I'm sorry, Jessie Cheng, we have 5 minutes again.
Okay, thank you. And for evaluation is on July 7th, the oxygen was adjusted to 40% of aerosol mask SpO2, which is 95%, and there was no respiratory discomfort. The second one for the long term is on July 18th, the patient didn't need to use oxygen during bed rest and walking, and the breathing pattern changed from shallow and fast to steady. The breathing rate was 18 to 20 breaths per minute, which is normal. So these are the discussion and conclusion. When I encountered this case, it was the first day when he was transferred to the unit from the intensive care unit. At that time, I observed that the patient was using high flow nasal CPAP oxygen. I was more nervous about the change of the patient's breathing pattern and afraid that the patient would have shortness of breath and asthma. Since the patient, if he doesn't use oxygen, the SpO2 value will be lower than 95%. So it's difficult for him to get out of bed, and which makes me feel more difficult to care of. However, after the follow-up teaching, the case can use spirometry and progressive in-bed activities. And eventually no oxygen is needed at all. When carrying this case, I feel very comfortable with the case. The case is at ease with the disease and life, rarely feel nervous and comfortable, and often encourages the nursing staff. I appreciate him since I received a sense of achievement by taking care of him. This is the reference list, and thank you all for listening.
Okay, thank you for Jessie Cheng for the presentation. Now we are going without the wasting time. We are going to the next presentation on the second session. Will present by Wu Cheng Kwang about the nursing experience about carrying the hopeless feeling of a colon cancer patient suffer from surgery in Taiwan. Time is yours.
Thanks for introduction from the host. Good morning, everyone. My name is Choi Kwang Koo, and I am delighted to be here today to talk about the topic, a nursing experience about carrying the hopeless feelings of a colon cancer patient who was suffered from the surgeries in Taiwan. This is a case report about the sigmoid colon cancer patient who was experienced twice surgeries and felt hopeless after surgeries. And the carrying period is from the November 11th to December 3rd, 2021. And we collected the patient's information by the ways of conversation, observation, and physical assessment in use of the theory of Royal's adoption model. The patient was concluded for the nursing problems as the following: the anxieties, hopelessness, and delayed surgical recovery. We provide the systemic and continuous nursing care for patient to alleviate the patient's pressures while he is in hospitalization. And we're going to, let's go to the introduction. What? Okay, the introductions, I need to mention about the colon and rectal cancer, what happened in Taiwan. The colorectal cancer has been among the most common malignancies in Taiwan more than 3 decades since 1993, and the colon rectal cancer is a submalignant cancer which influence the healthy populations in Taiwan. The incidence of the colon rectal cancer is highest for men and the second highest for women. But we have screen planned for people of the age between the 50 to 74 in Taiwan that can be freely used to know whether they were the patient once 2 years. The screen called fecal occult blood screening plan. But colon and rectal cancer is still the notorious disease among the Taiwanese because it is difficult carrying and the side effect of chemotherapy and even death. So many people are scared about the disease. So right now we're going to the case. My case is, his name is Mr. Shi. Gender is male and religion sex is. The blood is O plus type. The height is 168.3 cm and the weight is 86.8 kilograms. Past medical histories has diabetes, hypertension, and hemorrhage. The past surgery history is it occurred from the 2013 hemorrhagectomy and 2001 the orthoganic surgeries. My case was a 70-year-old male. He claimed he had abdominal pain and bloody stool for the past weeks. And he also described that he could find tumors by the way of palpation. As for a reason affecting his daily life, he went to the local clinic to consult of his health. Then he found that he had 4 cm colon tumor, up to 20 cm from the vent. So he came to our clinic to get further examination in November 8th. 2021. In our hospital, the CT shows sigmoid colon cancer with lymph node pace, and MRI suspect metastasis in the S7 part of the liver. Due to the above reasons, he was admitted to get further treatment. My cancer family tree is, he is a retired teacher from the colleges, and he claimed to living with his mothers in Miaoli, and he has 2 daughters, and he has 2 younger brothers and 5 younger sisters. Lucas and his wife have a daughter and a son. Both the children were adults. The elder daughter was in military working for a personal office in Taipei, and the younger son was a technician working for Type 5 enterprises in Kaohsiung. Thus, the economic situations was well off, and his wife had lived with his daughter's family to care their grandsons for a period. This time, the major caregiver in Veteran General Hospital was his wife. So we can see the timeline of the treatment. On November 8th, he went to OPD in Taipei Veteran General Hospital, and the next date, he get hospitalized. And November 11th, she got the surgery, the first surgery, laboratory low anterior resection. And the 17th, November 17th, he got the pole aid implementation. And in 19th, he got the redural surgery. The surgery called the Hartmann procedure, and he got a T-loop colostomy, so he has a bag in his abdomen. And he was discharged from December 8th.
原本的22个加1个数的嘛。
Right now, we are going to introduction the Roy's adoption models. The Roy's adoption models, we need to gather information from the patients, and there is a stimuli and adoption. They both, we need to assess their conditions, and we need to find which is the regulator and the cognator for the cause the nursing problem. And the effectors in Roy's adaptation models, they can define about 5 aspects. The first aspect is physiological part, and the second is the self-concept, and the royal, and the third is the royal functions, and the fourth is the interdependence. And we are focusing the assessment the fourth aspect. The first aspect is self-concept. We follow the guideline the schools give us. We, according to the guideline, to assess the patient, to find their, to collect the information, and to analyze their nursing problem. So we take a look at the positive, the body image, and the effective sexual functions, spiritual integrity, and physical growth, and the sufficient compensation for body changes, sufficient culprit method in laws. and the efficient period in end of life, and the sufficient integrations of own ideas, balanced, consistent, and efficient period in moral, ethic, and spiritual development, functional self-respect, and efficiency coping method in threat against oneself. So we got the information. So we are going through the subjective data. We got the 12 subjective data. The first data is the patient said, I feel uncomfortable about the surgery wound, but I seldom push the button of the PCA. And the next is he had lain on the bed since the surgery, and he just lied, not even moved, said the wife of the case. And the next, we were retired. There were no annoying things after their retiring, but anyway, the health body is much more important than anything, said the wife of the case. And the doctor says the recovery from the surgery is great. If it is normal tomorrow, my husband can be discharged from the hospital. The wife and the husband look so happy. Call phone to my son and tell him we can discharge from this hospital, the case said to the wife. And this morning, his stool is burned. It seems like a fecal blood, and his urine was red, said the wife of the case. The wife looks worried. And the doctor said to them, the doctor said to them that they should delay for being discharged. Today we need to make him hungry for a while, but I don't know what the mean is, said to the wife. And the visiting doctor told them that he would come to explain the condition to them, but he didn't come. We know he is very busy, so we don't call phone. In fact, we don't know how to do in the next step, said the wife of the case. And the wife felt tension and anxiety. I feel frustrated about the things occurring in my life, said the wife with a sigh. And the wife was shaking her hand resignedly. I was living in the hospital for a long time. I thought the fault was due to Shamei, the wife, the name of the wife of the case. Shamei was the reason making me here for so long, said the case. And in the beginning, I felt it was a small operation, but right now it was a huge operation, really a huge operation, said the wife, serious and frustrated. At the final, the tubes in my body are too heavy, said the case. That is, according to their dialogue, we collect the subjective data. And we're going to the objective data. The first data is, my case is a 17-year-old man. He is a retired military training teacher from college. His personnel are scanting of the walls. And the second objective data, the KESDAM laboratory low anterior resection because of 4 cm sigmoid colon tumor up to 20 cm from the anal vent. After surgery, he has several tubes and instruments such as NG decompression, JPGen, the PCA, and the Foley. And between the 11th to 12th November, the case was in MPO. He moved the title a little. He moved a little as a result of being afraid of worsening the wound. And between the 17th to 19th, the case sat on a coma for a period, and he was staring at the views outside the window silently. No conversation, just sitting alone. And on 17th, the biopsy of the pathogenic tissue was adenocarcinoma, T4N1B, and metastasis unknown. And the MRI scan showed the S7 part of the liver was suspected as metastasis. On 19th, the case needed reoperation on low anterior sections, Hartmann procedures, and T-loop colostomy because of ischemic colitis. The wound after surgery was saturated on the middle of abdomen, covering the viscosity, and his drainage tube was JP jammed 40 thumb and 40. The upright abdomen has a temporal colostomy. And on 26th, the reside doctor helps the wound remove stitch of the top 2 stitches and gave an order for wet dressing QID. The doctor also collected wound secretion to get a bacteria culture. The result of the culturing was Cutibacterium acnes. WBC shows was the white count shows more than 10,000 10,000, and the CRP was 5.7. The appearance of the wound have some yellow fluid. Every 4 hours, the outside gauzes can be weighted by the secretion. So, and we conclude the nursing problem for 3 parts. The first part is anxiety, because the data is according to the subject data and objective data, and it shows on the screen. The subject data is for 2, 3, 4, 6, 8, 9, 10, 11, and the objective data is showed 2, 3, 5, 6, and 7. The case, so we know the case is nervous, worried, and felt uncontent due to reoperation. And why we establish the nursing problem, our according is to the NANDA, from the NANDA definitions. So we find that the patient has the nervous and worried and feel uncertain. So we establish the problem, the anxiety. But our focus is hopelessness. So the hopelessness, we can find the data is associated for this problem. The subject data for 2, 3, 4, 7, 8, 9, 10, 11, and object data is 1, 2, 3, 5, 4, 5, 6, 7. And we can go through, see the data. The most important associated with the data from the subject associated with hopelessness is subject 2 and 8 and 9 and 10. And the subject 2, he had lain on the bed since the surgery and he just died, not even moved, said the wife of the case. And from the 8, the visiting doctor told them that he would come to explain the condition to them, but he didn't come. We know he is very busy, so we don't call phone. In fact, we don't know how to do in the next step, said the wife of the case, and the wife felt tension and anxiety. The subject night shows, I feel frustrated about the things occurring in my life, said the wife with a sigh.
Brother, we have 5 minutes again.
Okay, thank you. The wife was shaking her head resignedly, and the subject hand, I was living in the hospital for a long time. I thought the fault was due to Shame. Shame was the reason making me here for so long. And the objective data associated our problem is number 4. The case sit on a car mat for a period of time, and he was staring at the view outside the window silently. No conversation, just sitting alone. So we concluded the data from the collecting data that we can say the case is speechless of activities and has low spirit words due to the progress of the disease. So we established the nursing problem for hopelessness. And we can see the interactions among the nursing problems. There is the delayed surgery recovery and anxiety and hopelessness. We can find the cause and result. We find the hopelessness was the major nursing problems. So we have the care plan. The nursing problem, the hopelessness due to the progress of disease. So our nursing goal is the case can conversate activity with people about his thought and of the disease before the November 26, 2021. And the case and his wife can be active to tell things they would like to do right now and in the future before being discharged. So our practice for the goal 1, we intervened the patient before the case was discharged. I should accompany with people to gain more confidence as possible as I can, like assisting him to go off the bed or to walk. And the next is tell the case that I'm glad to listen and accompany with him when the patient felt he is bad. And be appropriate to give the case and the wife positive word and praise, such as you are awesome and you do a great job. For gratitude, my practice is encourage the case and the wife to listen to the music, which they like, to elevate their emotion and clarify their bad emotion was due to the progress of disease. And the first things they should to do was improving the uncomfortable condition. So after the interventions, we intervened the patients and we get the evaluation. On 25/11, the case told the wife that they would like to go climbing after being discharged. And he also helped to get earlier to leave the hospital. The next day, the wife helped the replacement of bag, and at the same time, she told everyone she do a great job, and she was a good caregiver. And since that, the case hadn't blamed his wife during these hospitalizations. And in December 1st to 3rd, the case can told us activity about his uncomfortable conditions, such as my left leg was unpanned. He felt there was a wound in his hip. And in December 1st, the case was being active and positive to our rehabilitating treatment. Okay, so what we learned from the case, as to a sigmoid current cancer, the mental nursing problem is difficult to assess. That is because they are suffered from the many physical restrictions such as diet, colostomy, and pain. Most of the time, they cannot talk to you many things about his thought. If we need to get more information assessment with the mental problem, we can take care of the dialogue between the case and the major case caregiver. There's much information you can get from their talk. And from the case, the most things that I learned is that they can't just learn. The things that I learned is they can't separate as a different part from the patient and his wife. The information the wife told is not for herself, but also represent his husband. So thank you for your attention.
Okay, thank you for both students, Jesse Cheng and also Huang Huang, who present us the material about bile duct stone and also the cancer of colon cancer. Sorry. Okay, if everyone, audience participant and student, if you have any question, just ask. Okay, we have a question from students of Nursing Academy.
Okay, I want to ask for Jesse Cheng. Can you hear my voice?
Yes.
Yes.
Okay. My name is Laili. I'm from Nursing Academy KESDAM 6 Tanjung Pura. First of all, I really appreciated your presentation. It was amazing.
Thank you.
In the case that has been explained on the 2nd of July, the patient had a fever, and the cause of the fever was suspected to be pleural effusion, which is diagnosed after surgery. So in my opinion, it can have an effect the provision of nursing care where there will be two perceptions. First, because there is a risk of infection after surgery, and secondly, there is inflammation in the body, so that it requires investigation. Therefore, I want to ask a few things. The first is how is the procedure before surgery in Taiwan? Because in Indonesia, the procedure before surgery requires the patient to take an X-ray so that the anesthesiologist can decide whether the operation can be carried out or not, because anesthesia has a big risk. Moreover, the patient is 64 years old with many complications such as hypertension, type 2 diabetes, hyperlipidemia, and left kidney suspected adenoma. And the second, as we know, pleural effusion, calculus of bile duct, and cholangitis can occur repeatedly. I want to know how health education is applied in Taiwan to patients and families. Thank you.
Okay, thank you for your question. And for the first one, did I misunderstand that? Do you mean by why do we still give the surgery even if he is on fever? Do you mean by that?
No.
Like why do we still give the surgery even if he's fever, right?
Mengapa harus operasi pada saat dia demam?
Oh, no. I mean the fever cause of the effusion, pleural effusion. I want to ask, how is procedure surgery in Taiwan?
So we won't, the fever of his is after the surgery, not before. After the surgery, he got a little bit of mild fever.
She asked you how the procedure in Taiwan before the surgery. If the patient, the patient for 60 years old, so he so many disease such as blood. So how do you know that the patient ready for the surgery?
So we'll do the pre-surgery examination to make sure that he's fine with the surgery. And then because, yeah, that's it. They will make sure that it's fine for him to go through the surgery for his like long-term problems, like hypertension, the one that you mentioned. Yeah, they'll do the body examination to make sure that it's fine for him. The pre-anesthesia examination, which is not caring from the nursing team, which is from the anesthesia team, not from nursing.
Perawat itu kan berhubungan dengan anestesi. Ini pasien bisa ketemu di operasi. I mean, in Indonesia, the procedure before surgery requires the patient to take an X-ray. So the patient and the anesthesiology and nurse can decide whether the operation can be carried out or not.
Yeah, so they did the surgery was on June 30th, and they did several examination on June 6th, which is on my first page of case presentation. They figured that the right intrahepatic bile duct was dilated, suspected cholangitis, as I mentioned, and several problems from the left for the left kidney. Yeah, but specifically for the surgery, is he fine or safe to go through the surgery for anesthesia? Since he has this high age, the anesthesia will go through the examination from them. Yeah, did I answer?
Jessie just mentioned the list of the examinations tests that this patient actually had done before the surgery. I think this lady is asking about that. What kind of?
Asking about that, yeah.
We have all the.
Oh, okay.
What are they?
Sorry, so we've done abdominal computed tomography examination and arrange for liver MRI examination. Yeah, that's the main two examinations.
So we have regular blood tests and chest X-ray, pelvic ECG. That all has to be done before the surgery. That is the protocol. That's the standard in Taiwan before you actually go on with all kind of surgeries. So pelvic ECG, blood tests, and also like chest X-rays and all the MRI, CT scan or abdominal scan depends on the type of disease and symptoms.
Yang kedua, how is health education? Okay, the second question is, how is health education in Taiwan to patients and families?
The health education part?
Which part of health education is the lady interested? Which part?
Okay, so
what did you actually do with health educations or family education, Jessie?
Okay, for implementation, Plan 5 is to inform the case, family members, and caregivers, and assist the case in adopting progressive out-of-bed activities, which can promote lung expansion, which is one of the main concepts in health education. And they should pay attention to prevent falls when getting out of bed. Yeah, which is under P5. Did I answer your question? Sorry.
I get the point. Thank you so much.
Yeah, thank you.
Okay, thank you for Lely and Jessica for the discussion, interesting about the bile duct stone. So, does participant audience and student still have question? Mr. Eric, do you have question? No.
No.
Okay. I also want to thank you for the two presentations presented by the students from Taipei. And I also wanted to actually close this student sessions. And I think both students from two countries somehow use different, we have similar concept using Nanda. So we talk about nursing care plan. And should I say the nursing care from Taiwan that we require our students, we encourage our students to use theory and model. So Jessie used a Golden 11 functional care plan. This is often used for adult care. We encourage our students to actually use family tree. So you can see that a lot of nursing diagnosis, some of the nursing diagnosis we used related to family problems or psychological, emotional issues related to the patients. But in pediatric, I must say, Golden 11 functional assessment, it's not that useful, okay, in pediatrics. But in adults, it's actually quite useful if you want to use Golden 11 functional assessment. For Jie Guang, we had a colorectal cancer. We look at, because this patient actually in the end had a metastasis. So the immediate problem is that the feeling of hopelessness, because what kind of, and any kind of treatments might not be effective in the end. That means that the patient with colorectal cancer cannot fully recover. So he's initially he used Royal adaptation model, but in the end, I think Watson's current model might be a better choice, because his report is about feeling of hopelessness. I know some of the students from KESDAM, Indonesia, is interested in the bowel health education, the real health education that we delivered in Taiwan, specific to the patient or family related to particular illnesses or treatments. However, in today's situation, very limited time, we can't actually give you the real health education that is actually given to that particular patient with that particular disease and treatment because of limited of time. And also, most of the health education given, of course, in Taiwan is in Chinese. Maybe next time when we have a full English seminar, maybe we can have particular, more specific topic and relate to health education. Maybe that's much more, focused. Not at this time, because the time is very limited. But I think that's well questioned. That means that you urge for information from the students in Indonesia, which is really good. That's very, up to the learning bit, which is wonderful. Okay, so today our focus is on healthcare plan and how we actually conducted, and we actually share some of the information, similarity and differences between two countries. Students are doing well. They highly motivated, which is good. I think this is all about teaching and learning. We want the student to learn, and it's never imperfection in the first time, of course, but we always try to learn from our like up and down. This is what we learn in our learning curve. And so thank you for the invitation from KESDAM, and thank you for the handsome man from the host and Eric as well, and also thank you for the Deputy Director Bada, and all the presenters, giving us this wonderful opportunity to learn from each other. So I will, terima kasih. I will just stop talking, and hopefully next time in the near future, we'll be able to see on air. Thank you.
Okay, Mr. Eric.
Yeah. Go ahead.
Oke, ada tambahan?
Nggak ada, Mas. Silakan diteruskan.
Okay, thank you for some suggestion, comment, or something like that from the professor. And of course, if we have a long time, so we'll more discuss about the nursing curriculum, of course. And we hope, I wish we will meet again, and of course, the same topic on maybe more than about the nursing curriculum, about how to teach, how to give education for the family, for the patient, and of course for the nursing, of course. Thank you.
Goodbye, everybody.
Maybe before we close, maybe we can turn on the camera and then we take a picture together, the whole audience. Is that possible, Mr. Host?
Okay, before we take a picture together, I would like to close our event today. Director of Nursing. Sorry. We also hope that this event feature invites the educator, especially nursing, to be more millennial, provide new idea to be more progressive in the future. I appreciate for the staffs, students, lecturer, nursing academic KESDAM 6 Tanjung Pura who have organized this extraordinary event. We are also giving high respect and gratitude for all the speakers, Professor Catherine Weng, Dr. Stacy, Mr. Agianto, and also Mrs. Baida, who has the shared knowledge and also the experience to us. And also I would like to thank you for Mr. Eric, who has this as translator, guide, and also intermediary between National TV University and student and Nursing Academy KESDAM 6 Tanjung Pura. I would like to thank you for Brother Kucheng Kuang and Sister Jessie Cheng, also the shared knowledge and also the research, of course. And at this moment, we would like to some words will be delivered by the first deputy director of Nursing Academy KESDAM. Please, ma'am.
Terima kasih Pak Arif, Mam Catherine, sudah bersedia meluangkan waktunya untuk kegiatan ini. Plus saya Prof dengan mahasiswa dari NTHS luar biasa, kita bisa sharing pengetahuan. Kami juga bisa belajar lebih banyak lagi. Mudah-mudahan kita bisa mengadakan kegiatan bersama lagi. Mungkin kami juga nanti dapat undangan dari sana, ataupun nanti kami juga mengundang lagi untuk ke NTHS. Mungkin nanti lewat perantara Pak Arik ya. Kami sangat terbantu dengan perantara Pak Arik. Terima kasih banyak. Dan ada titipan dari Ibu Direktur, ucapannya sangat berterima kasih. Karena ini pertama kali kami mengadakan kegiatan internasional, baik mahasiswa dan dosen. Walaupun MOU itu 2018, tapi pelaksanaannya baru sekarang. Oh iya, Prof. Catherine, ini untuk kemarin Pak Arik ada cerita masalah program beasiswa untuk mahasiswa dan dosen. apakah mahasiswa kami dari D3 keperawatan bisa mendapatkan beasiswa S1 di tempat Prof, dan juga untuk dosennya kalaunya ada, mungkin kami bisa menyiapkan mahasiswa kami 1-2 orang, nanti setelah mereka lulus kami akan siapkan. Oke, gitu Pak Arif.
Okay, so Professor Catherine, she said that the director of the president of the KESDAM nursing school say thank you so much for this opportunity, because this is the first time they are conducting the first international activity with NTU and NHS. So they really appreciate, and they are asking about the possibility to continue the students the education to NTU NHS next time for master or PhD. Tapi kalau di NTU NHS itu untuk internasional programnya hanya master dan PhD, Bu. Jadi nanti kalau misalnya ada lulusan dari S1 ke S1 ke S1 bisa lanjut ke S2-nya program kita. Tapi kalau yang S1 belum bisa karena masih full Chinese. It's not English.
Oke, makasih Pak Arif.
Ya.
Mungkin kegiatan ini dari kami mungkin banyak kekurangannya Pak Arif, dari mungkin dari persiapan dan juga pelaksanaan. Mohon maaf, mungkin penerimaan via Zoom kami tidak begitu bagus. Mohon maaf ya Prof.
No, it's a good, right, Professor? The activity is really running smoothly, right?
Iya, mudah-mudahan nanti kita bisa bertemu secara tatap muka, Prof. Face to face.
Yeah, next time we will invite you to Taiwan, of course.
Yes. Welcome. I'm sure COVID-19 will be settling one day very soon. We all have our vaccines already. So I'm sure the border will actually open soon. But I think it's important we keep ourselves healthy. Okay. And we talk about a lot of respiratory assessment and respiratory health today and yesterday as well. So I think it's important that we all keep ourselves, vaccinated and also healthy exercise. So I think in the future, I'm sure we will meet each other. And Eric is a person that actually help us to link with Taiwan, our university, and also with a lot of university in Indonesia. So Eric is our friend and he's our PhD student as well. So I'm sure he is able to help us to share some information with you as well. Thank you very much for all that. Well, we are very honored and happy to meet you here in Taiwan soon.
Oke, itu aja Pak Arif yang bisa saya sampaikan. Terima kasih banyak. Thank you, Mom. Mungkin yang lain pengen lihat.
Okay, this is
yang di belakang layar.
Okay, this is our staff, our lecturer, our student in behind of the screen or camera. This is students Laili, Lingga, and Mrs.
Balik layar, Prof.
Behind of the camera, Miss Weni. Of course, the lecturer of the nurse, and it's our second deputy director.
All look very handsome and beautiful. Okay.
Okay, this is Mrs. Purwantin, also Mrs. Soraya, head of information health information management as a dean health information management program, and besides of her is my wife also. Thank you.
Balik layar, Prof.
Wife is important. Wife are, the number one people.
Okay, can we some picture together, or I mean screenshot?
Screenshot, mau di screen. Wajah cantik.
Jadi siapa yang screenshot ini?
I think everyone need to turn on the camera so I can help you to screenshot through my devices.
Okay. All the participants, please turn on your camera so we can take a screenshot together.
Sini.
Ready?
Kelihatan kah? Ya. Kadet.
Apanya? Okay, wait 4 minutes. We of the background. Udah?
Okay. Okay, ready?
Wait.
Okay.
Scroll ke atas. No. Yeah, no. Okay, from the count 1, 2, 3, please say cheese. Okay, Mr. Eric, could you?
Right, I will help you to count. Okay, ready? 1, 2, 3, cheers. One more time. 1, 2, 3, cheers. Okay, next slide. Because there is so many audience, so I need to move to another slide. So keep staying on your camera, and then I will count one more time. 1, 2, 3, cheers. 1, 2, 3, cheers. Okay, next slide, because there is 4 pages. Okay, 1, 2, 3. 1, 2, 3. One more pages. 1, 2, 3. 1, 2, 3. All right. End it. Thank you.
Thank you. Goodbye, everybody. And terima kasih. Bye-bye. We'll see you next time on it. Thank you. Everybody. Thank you, Eric.
Thank you.
Bye.
Kai Chang, and thank you, Sister Jessie Cheng, Mr. Eric.
Thank you, Mom Catherine.
Thank you.
Cecen, Sisi.
Terima kasih ya.
Banyak ya, Pak Eric.
Saya juga ucapkan terima kasih kepada Akper KESDAM. Tolong sampaikan terima kasih saya kepada Bu Direktur. Hari ini nggak hadir, nggih? Ya. Sama teman-teman yang ada di Akper KESDAM, terima kasih atas kerjasamanya. Kita sudah persiapan hampir dari bulan kemarin ya, sebelum tahun baru.
Desember, Pak.
Nanti kalau misalnya ada ada hal-hal yang ingin ditanyakan terkait dengan admisi, ini program kalau misalnya ada dari Akper KESDAM yang menginginkan untuk dilanjut, ini sudah dibuka Ibu Baidah. Jadi misalnya ada yang master mau S3 dosennya, ini sudah dibuka program admisinya nanti sampai tanggal 14 April, jadi masih 2 bulan lagi admisinya sudah dibuka. Ada beberapa beasiswa yang ditawarkan, jadi bisa mungkin dicoba.
Ya Pak, nanti akan kami siapkan untuk dosennya.
Iya.
Orangnya Pak.
Izin Pak bertanya untuk Pak, untuk yang jurusannya apa aja Pak di sana Pak, ada Pak?
Kalau yang sekarang program internasional ini untuk S2 atau S3?
S3 Pak.
Oh, kalau yang S3 kita program internasionalnya baru buka nursing dan midwifery. Kebidanan dan keperawatan. Tapi kalau yang S2 kita ada kebidanan, keperawatan, kemudian sport science, medical information, healthcare management. Jadi nanti kalau misalnya ada mahasiswa lulusan S1 healthcare management atau sport science atau Montessori program yang mau S2, kita ada. Tapi kalau yang PhD baru ada nursing dan midwifery untuk program internasionalnya.
Alhamdulillah. Untuk tesnya Pak, bahasa Inggrisnya pakai TOEFL kah atau IELTS?
Kami menggunakan 3 tipe English proficiency test bisa pakai TOEFL ITP, TOEFL IBT, dan IELTS.
Waduh, mati kita.
Tapi kalau misalnya fluent in Mandarin gitu ya bisa pakai TOEIC.
Oh, entah. Tweaknya yang susah, Pak. Ada.
Ini kalau dari Indonesia ini banyak sekali yang sudah daftar sih, Bu. Kalau kemarin saya pantau karena ada privilege beasiswa untuk dosen sebenarnya dari Kementerian Pendidikan di Taiwan, itu namanya Elite Scholarship, Elite MOE. Itu coverage-nya full scholarship ditambah uang bulanan sekitar 7-8 juta per bulan. Itu uang sakunya saja, itu di luar dari biaya dormitory, buku, asuransi, dan sebagainya. Jadi kalau kemarin saya dapatnya yang Elite Scholarship untuk khusus beasiswa dosen.
Ih, mantap. Kami susahnya bahasa, Pak.
Dipersiapkan bisa. Itu belajar sama Mas host.
Pak Ahmad namanya, Pak.
Pak Ahmad ya, soalnya nggak ada namanya. Salam kenal Pak Ahmad.
Apa yang namanya ya?
Oke.
Oke, nanti kalanya ada informasi atau kami ada ini, kami nanti akan hubungi Pak Arik ya, Pak.
Ya, silahkan monggo.
Oke, punten, Pak.
Iya, saya izin pamit ya Bu ya, persiapan untuk sholat Jumat. Jadi terima kasih sekali lagi untuk Akper KESDAM atas kesempatan dan persiapan dari awal sampai akhir, dan alhamdulillah insya Allah berjalan dengan lancar dan well prepared insya Allah. Dan kemarin saya dapat tanggapan dari NTU-NHS sangat puas dengan kegiatan ini gitulah, dari Prof. Catherine sendiri. Jadi sangat antusias untuk mengikuti kegiatan ini dari awal. Mahasiswanya juga sangat antusias untuk mengikuti kegiatan ini. Hanya saja kita tidak bisa menyiapkan lebih dari 10 mahasiswa. Kayaknya yang hadir hanya 9 atau 10, tidak bisa 30 karena masih liburan Chinese New Year ini sebenarnya. Masih liburan Imlek, kalau di sana liburnya 15 hari. Jadi pada masih liburan dan nggak bisa diganggu kadang-kadang. Mudah-mudahan untuk kedepannya silaturahminya tetap terjalin, untuk kegiatan-kegiatan ke depan bisa lebih dijalankan lagi. Apapun itu nanti kalau misalnya ada hal-hal yang ingin kegiatan yang ingin dikolaborasikan dengan NTU-NHS, nanti bisa kontak saya buat deskripsi kegiatannya. Insya Allah nanti akan saya komunikasikan dengan beliau-beliau.
Terima kasih, Pak.
Izin ya, pamit ya. Salam buat teman-teman semua yang ada di Akper KESDAM. Pamit. Assalamualaikum.
Om Jogja. Alhamdulillah. Tepuk tangan.
Nggak ada absen kan?
Bitle. Absen Bitle. Dua kali terakhir. Ya. Thank you teman-teman. Akhirnya kita selesai juga.
Yang pertama mana?
Masih Pak Arik. Pak Ahmad makasih banyak ya. Nanti Pak ya Senin titipan dari dirnya. Jadi sudah pulang.
Yang dari Buraya ini yang pertama.
Thank you. Hah? Bujurnya bulik. Bulik. Awas dah. Aku jangan sempat. Aku nyuruh Raminya lambat banget. Tadi itu. Sudah lagi ngetik.
Yang kedua yang mana?
Ya Bu, ini baru selesai nih acaranya Bu. Oke, Angge siapa? Angge. Nah, kan tadi anak mana? Tadi Rizk mana? Mana Pian? Angge, berapa jar? Pian.
Nanti dibongkar jilitannya.
Bukan gini sekolah. Ayo makan. Jilid aja, kamu kalau sudah.